to enjoy a good meal and a bottle of wine together. What I'm going to talk about tonight is the evolution of minimally invasive spine surgery. One of the bad things about being, or the good things, I suppose, about being as old as I am is that I've been here for most of the evolution of minimally invasive spine surgery. I got to watch it, and I got to know all the people that were making such seminal contributions to the way we do surgery today. And I thought I'd go through that and the various trends that developed over time in the development of minimally invasive spine surgery. So the principles of minimally invasive spine surgery that we set forth very early on was that the surgery had to be minimally invasive. And that meant that it had to disrupt soft tissues less, require less intensive care, shorter hospital stays, have less blood loss, less pain medication, and it has to satisfy all of those things to be minimally invasively. In addition, it had to be technically not unreasonable to perform. If only a handful of people can do an operation, it's not a very good operation. So technically, it had to be something that every surgeon would be able to do. It had to be done in a reasonable period of time, and it had to be applicable to many procedures. It's not reasonable to spend $200,000 on a surgical device and only be able to do it on one or two operations that you do once a month or once every 2 months. So it had to be a reasonable cost. Most of all, you had to be able to get the job done, and you had to be able to do that without increasing your complication rate. So the first trend in minimally invasive surgery was for the procedure to be as minimally invasive as possible. And the operations that satisfied that were chemonucleosis, automated percutaneous laser discectomies, IDET, it was automated percutaneous lumbar discectomy, IDET, and then laser discectomies. And then ultimately those evolved into visual guided foraminal surgery. So that was one trend, make it as minimally invasive as possible. The second trend was to get it all done through muscles and soft tissue sparing surgery. And those techniques came about as minimally invasive endoscopic surgery, minimally invasive decompression of stenosis, tubular transforaminal lumbar interbody fusion, eventually evolving into deformity surgery done minimally invasive, intradural surgery done minimally invasive. So we were able to do virtually all of our operations through muscle-sparing technologies. And the third trend in minimally invasive surgery was an increasing reliance on image guidance, initially with fluoroscopy, evolving into fluoronavigation, to intra with enhanced visualization within the tube, percutaneous instrumentation, and then image guidance. So first of all, let's talk about approaches, and let's talk about the posterior approach. Some of our operations, the very first operation I ever developed was anything but minimally invasive. It was called the lateral parascapular operation, extrapleural, and it was specifically designed to be able to approach the T1 to T4 region, which otherwise is very hard to get to. You can't get to it anteriorly because the great vessels are in the way, the arch of the aorta and the brachiocephalic vein. It's very hard to get to laterally because the apex of the chest cavity gets so small. You can't get to it posteriorly because the spinal cord is in the way. and it was very hard to get to it posterolaterally. So what we figured out how to do was to make a midline incision and take the paraspinal muscles ipsilaterally and retract them to the contralateral side, and then take down the scapula with the rhomboid muscles and the parascapular muscles, reflect them laterally, and that exposed the entire lateral aspect of the rib cage. But that was anything but minimally invasive. Now, I'm going to show you later on how this operation can be done minimally invasively. And then, of course, we have our open posterior procedures for deformity, for example, where we expose the entire posterior elements of the lumbar spine, sometimes all the way out to the transverse process. And in the process doing that, we devascularize that muscle and we denervate that muscle so it becomes essentially dead muscle. Well, our first attempt at doing anything minimally invasively was reported by Valls and Anolani in JAMA in 1948. They used a needle to do vertebral body biopsies for tumors within the vertebral body. The same year, Key and Ford in Journal of Bone and Joint Surgery reported on doing discography to actually visualize the interior of the disc, and by doing that, to be able to, let me see if I can go back, to be able to actually visualize defects in the annulus and diagnose herniated discs. And here later on a CT scan came 20 years later, we're able to see that very well. So this is a post-discography CT scan. Well, once we knew we could get into the disc space, became obvious that we don't want to just diagnose that there's a problem. Is there a way that we can take care of the problem without doing surgery? And that first technique was chymopapine, reported by Smith, again in JAMA, in 1964. So the disc space was entered percutaneously from a posterolateral position. After injecting some dye to prove that you were there, then chymopapine was injected to dissolve the interior of the disc space. This received a number of complications in the United States, which eventually led to it no longer being allowed to do, and that happened because of leaking of the chymopapine into the intradural contents and causing paralysis. Still, it's done worldwide, but not in the United States. Well, then obviously the next step was if we can put a needle into the disc space to diagnose something, and we can put a needle in to inject chymopapine, why can't we make the needle a little bit bigger and put in an instrument to actually do a direct decompression? And the first report of that was Hijikata in 1975, where he reported a percutaneous disc decompression. But then Cambin became particularly well known in 1983 for really advancing that technology. So Gary Onek, a radiologist, an interventional radiologist, 1985, developed and published what he called the automated percutaneous lumbar discectomy. This was the first percutaneous procedure that I ever learned back in shortly after, when I was a resident, shortly after 1985, and it came through a series of instruments that you were able to purchase the interior of the disc and then go into it with a series of small curettes and pituitary rongeurs to take out pieces of disc. The next step then was saying that, well, the problem with that technique is that it's blind. You really don't know what you're grabbing, and therefore, if you're in the wrong position, it could be quite dangerous. So by taking that portal then, adding light and camera, in 1981, Schreiber and Loy first reported a biportal discoscopy where they would put a light and camera in one portal and disc removing devices in the other to actually do an internal decompression. And Cambin then developed his, where he put both the lights and the camera and the working channel in the same device, so he was able to do a uniportal discoscopy and discectomy. Hans-Georg Loy in 1986 then really popularized what was called foramenoscopy, where you enter the foramen, view the internal contents of the disc, and do a discectomy. Many others since then have championed this with their own techniques. Anthony Young is one of them with the selective endoscopic discectomy technique. Philson Choi has his own system as well. And this technique is now done worldwide to quite frequently on a massive scale. The next thing that happened, though, was the argument that although that's a great technique for selected cases, it is relatively expensive, and there's really only a couple kind of cases you can do with it. So it's relatively limited and therefore not terribly cost effective. So the next technique that began getting developed was to put in a larger tube and using either an endoscope or a microscope or eventually loops to be able to do the same operation you would otherwise do through open technique, but do it through a tube instead. Most people know Kevin Foley and Mo Smith for developing this, but actually the first person to do this procedure was not a spine surgeon. He is best known for doing radiosurgery, and that's Bill Friedman at the University of Florida, did the first tubular discectomy through a chest tube, actually, back in 1983. Wolf Kaspar then developed tubular surgery in 1985 using a microscope, and Kevin Foley and Mo Smith developed the endoscopic tubular discectomy for doing disc herniations in 1996. Since then, we have expanded this technique to be able to do virtually every operation we do through a tube of varying sizes. This demonstrates a cervical foraminotomy and discectomy posteriorly. This demonstrates a postoperative patient. This was a police officer who had 3 adjacent level disc herniations. Normally, I would not do them open, so I would have told her not to have surgery. But since we were able to do it minimally invasively, we did two from one side, 1 from the other, and she was able to go back to work as a police officer. This shows you the extent of exposure you can get for doing a thoracic disc, so you can easily get to midline through a simple posterolateral approach. And this shows an exposure of an intradural schwannoma in the thoracic spinal cord with multiple lobulated tumors that was able to be removed through a 25 millimeter tube. We also do sectioning of tethered cords this way. This unfortunate individual had a bullet in his cervical spinal cord. Normally, I mean, he was quadriplegic, and normally I would not do that operation, but both his mother and the police asked me to do it so they could have the bullet as evidence in the prosecution of the person who sent him. And then this shows a relatively large syrinx that we also are able to drain minimally invasively. So we're able to do pretty much everything now through minimally invasive technique. This showing an 18 millimeter tube coming down with dilator and doing a transforaminal lumbar interbody fusion. So here you can nicely see the edge of the dura, the exiting nerve root, the disc right above it, and showing the typical exposure we will get to do that, where we have pedicle to pedicle exposure and able to do a very nice discectomy, put in our cage, and then do percutaneous instrumentation behind that. This is a patient who had thoracic vertebrectomy with an anterior reconstruction with a cage through a 25 millimeter expandable cage called the X-tube that would expand up to 40 millimeters. So for example, in this patient, this was a farmer, a divorced woman who ran her own farm in North Dakota, who came to me with this large compression fracture and retropulsed bone fragment. She was neurologically intact, but was in so much pain that she could not run her farm anymore. Now, prior to minimally invasive surgery, if I had done the lateral extracavitary or lateral parascapular operation on her. That is such a large operation, even though we can reconstruct the scapula and the rhomboid muscles. I don't think she could ever have gone back to running her farm. But through minimally invasive surgery, we were able to do a vertebrectomy of that level, use her own rib for an anterior reconstruction, and do percutaneous instrumentation. I followed her for 12 years out, and she was still running her farm. This unfortunate gentleman has multiple myeloma, which has completely eroded both of these vertebral bodies. He had undergone all the chemotherapy that he could get and had undergone all the radiation therapy he could get. So he really had nothing left. And as you can see, he was starting to collapse off to the side, so he was very unstable. So doing a minimally invasive approach, we were able to access that, do a 2-level vertebrectomy, put in an anterior cage, and because he had already had radiation therapy, I wanted to minimize his incisions as much as possible. So rather than doing bilateral pedicle screw systems, we did a unilateral pedicle screw and then a vertebral body screw, which Ed Benzel described as being biomechanically equivalent to a bilateral pedicle screw system. So by doing that, we were able to minimize his incision to a single 6-centimeter incision, and fortunately didn't get into any healing problems because of that. So what's going on now is we are advancing to the point, even with the transforaminal endoscopic techniques, where we can do larger operations on an outpatient basis through completely a really minimally invasive technique. So by putting in an 8 millimeter tube with camera and light, we're able to go in. This is a case of Michael Wang's, where he goes in, he does a discectomy, he puts in the Bagby the Bagby bag and fills it up with autologous bone, and then comes out and does percutaneous pedicle screws. And it's completely done with an awake patient as an outpatient basis. I've seen him do it. It's about an hour procedure. It's remarkably fast. So this is even less invasive than our T-lifts. And depending upon how his fusion rate is with this, it may or may really be another step forward. I'm also familiar with several companies that are doing development, what they call procedural solutions, through an 8 to a 10 millimeter tube, are able to go in and do facetectomy, discectomy, anterior reconstruction with a standard cage, and then percutaneous posterior instrumentation, which again can be done as an outpatient under local or general anesthesia, and can be done in surgery centers. So we are making advances in these areas to allow us to do even more minimally invasive surgery. Okay, now let's go to the anterior approach. So this is showing a standard anterior laparotomy for an ALIF. And shortly thereafter, we went to thoracoscopy and abdominal endoscopy to do our interbody fusions. So in thoracoscopy, we would make an incision, insert a camera, 2 other incisions for a retractor, and our working instruments, beautiful displays of the anatomy. We're able to get in, incise our disc, take our disc out, as shown in these, and then even do vertebrectomies and put in this case, a femoral allograft bone, and doing that all under direct visualization. In 1994, Mike McMillan and I developed what we called the RELF procedure, retroperitoneal endoscopic lumbar fusions. So in this case, we're doing 4 portals, 1 for a retractor, 2 working instruments, and 1 camera to expose our vertebral bodies, do a discectomy, and here you can see what our technique is. These 2 Steinmann pins are retracting the iliopsoas muscle. So in that regard, it's sort of like the technique that's being done now for the oblique the oblique ALIF. This was essentially the same thing, where this is going in front of the iliopsoas muscle, which we've retracted with these pins. As you can see, that muscle is retracted here. That exposes the entire lateral side. We don't have any worries about the femoral nerves. And then we can drill out a nice space. And this was a femoral allograft that we put in. That was published by McAfee again in 1995, by Zuckerman and Zedeblik, all doing it laparoscopically. Now, that was a tedious and a technically demanding technique. And what that eventually evolved into, though, was the direct lateral, or the X-lift, or not what we generally call L-lift now, so that we don't give any industry preference. But so the retroperitoneal endoscopic lumbar technique that McMillan and I developed eventually turned into the lateral lumbar interbody fusion, where we can go in and put our new cages in, and it's technically now a much easier procedure, multiple different retractors that you can use for this system. I used to use the metric system from Medtronic. I now typically use different systems, but they all give you, excellent visualization and excellent room to do your procedure. Whether you're doing it transpsoas or oblique in front of the psoas, doesn't really matter. This shows how very nice exposure you can get down there. We already have 2 cages in place in this particular patient. You can see the screws in place, holding it in place. And this shows you how nice of an exposure. Here's the radicular artery coming around. This is the disc space that's been exposed. And then moving on from that to percutaneous instrumentation. First percutaneous instrumentation done were Schanz screws done by Magaro and reported in 1984. And those were for long bone fractures, to set them and allow them to heal. Those were then translated into the lumbar spine. The problem with those was that you had instrumentation going from vertebral body all the way out of the skin. And there was a moderate infection rate with that. So Schreibner and Loy again in 1989 reported using a biportal percutaneous discectomy and Schanz screw stabilization. So a completely minimally invasive discectomy and stabilization. And they were the first to report a completely percutaneous technique. In 1995, Mike McMillan developed what he called the transsacral L5S1 fusion and instrumentation. And we were partners at this time, so I did quite a few of these with him. What this did was it went transsacral through the gluteus muscles into the ala of the sacrum through the L5S1 disc space, where you would do a discectomy and then pack it with bone and then put cages through into the L5 vertebral body. So this was a bilateral L5S1 percutaneous instrumentation, fusion and instrumentation, done completely minimally invasively through the buttocks, and this was an outpatient procedure. On the other hand, because of the complex anatomy of the sacrum and the pelvis, this was very difficult for people to do. Eventually, that evolved into the axial lift, coming from the front, going behind the rectum and bowel, and then drilling, again, doing the same thing, drilling through the front of the sacrum, doing a discectomy, packing it with bone, drilling into the body of L5, and then putting a screw up in the body of L5. I personally have never been a proponent of this technique. The reason for that is the technique that McMillan developed was a bilateral technique, so it gave you very good crossing or the instantaneous actions on rotation. In this technique, it goes immediately into the instantaneous axis of rotation and therefore has very little ability to control flexion extension or lateral bending or turning. Our fusion rates without posterior instrumentation in the technique of McMillan was only 65%. And that's the problem with this technique, is that without posterior instrumentation, it has a very low fusion rate. The next thing that happened at that time was doing percutaneous vertebroplasties. The original ones of these were done in France, and then we transported it over to the United States and all of the other countries, and we realized that we could put a large needle through the skin, through the muscle, and into the pedicle and vertebral bodies, and then fill the vertebral bodies up with methyl methacrylate. Well, if we could do that, then why can't we put in a pedicle screw down that same pathway? So in 1995, Hal Matthews described percutaneous pedicle screw instrumentation, but he was using suprafascial rods. That had a very high infection rate. Cambon, the next year, described the same thing with percutaneous screws, but doing subfascial pedicle screws, and that worked out much better. 2000, Kevin Foley then developed the sextant, which was our first truly percutaneous system, where you would put the pedicle screws in percutaneously, hook up their extensions, and then run a guide through them. Interestingly enough, this guide was developed off the guide that Mike McMillan had developed to do the percutaneous transsacral fusions that I just described to you. So this technique, the sextant technique, had already been used for a number of years by McMillan to do those transsacrals, and it was adapted to do the pedicle screws through the sextant technique. Kevin and I then reported several techniques of doing extreme lateral, PLIF, transforaminal in 2000, and this was the first totally percutaneous fusion and fixation technique that was easy to do and had a high rate of success. But this was then even developed further to do multiple levels. For example, here was a compression fracture for which we did a pedicle subtraction osteotomy that you can see here, put in our pedicle screws and then distracted on them, and you can see how much distraction we got by pulling these pedicle screws apart. That led also then to percutaneous deformity. If we can do all of those things, if we can do lateral interbody fusions, anterior lumbar interbody fusions, all through minimally invasive technique, and we can do percutaneous pedicle screws, we ought to be able to do deformity. And ultimately, it turned out we could do that quite easily. So the techniques of deformity that are used now is usually, I prefer a single midline skin incision, because cosmetically it's much nicer than multiple small incisions. And then by doing everything else, by dilating through the fascia and the muscle, doing our interbody fusions at 5-1, 4-5, 3-4, 2-3, maybe even 1-2, facet fusions above that, and then minimally invasive pedicle screws. And then we were able to do relatively large coronal deformities and get them very nicely straightened out with excellent lordosis. As our techniques have evolved now, we're able to do all the way from T2 all the way to the sacrum and iliac wings, getting excellent restoration, all minimally invasively. We usually use anterior lumbar interbody fusion at 5-1 and 3-4, laterals at 3 levels above that, facet fusions above that. We do large double majors now, and we've dropped our blood loss from between 2 and 3 liters with these large open techniques to about 200 cc's. So it's even rare to have to do a transfusion in these patients, and they really do quite remarkably. So over the course of my career, when I started my spine career in 1989, I was a completely open surgery. I did everything open. And over the years, when we were able to develop the transsacral procedure, the retroperitoneal endoscopic procedure, thoracoscopy, minimally invasive discectomies, cervical minimally invasive discectomies, decompression of stenosis, TLIF with sextant, thoracic minimally invasive discectomies and corpectomies, extradural tumors, vertebrectomies, tethered cord, shunt placement, and then intradural tumors and scoliosis. I've evolved to the point where I don't do any open surgery anymore. And in addition to my patients appreciating that, it's made my life much easier as well. So the question is, what's going to happen tomorrow? And I often get the question from my residents and fellows who come to me and say, you know, it looks like everything that can be developed in minimally invasive surgery already has been developed. What can we do? And what I tell them is, first of all, I give them a quote from the director of the Patent Office of the United States Patent Bureau back in about 1899. And at that time, he said, everything that can be invented has been invented. How crazy was that? So what I tell my residents and fellows and the younger guys that ask me, younger guys and women that ask me, where can we go? I see several areas that are ripe for creativity and inventiveness. One is that although image guidance is good now, until it becomes real time, it's not going to be completely safe, and it's not as good as it can be. So we have to move image guidance into real-time image guidance. And once that happens as well, then I think haptic technologies are going to have a real place in open surgery. We still have a lot of development to do to make our larger procedures smaller, less pain, outpatient, and available to do them in surgery centers. And I see the advocacy of biotechnologies as being a huge part of our future. So those are the three areas I see ripe for development for minds that are keener than mine and have the time to go ahead and develop them. So although I say that, Yogi Berra said, I never make predictions, especially about the future, and I really would never want to do that. So I do keep in mind, though, that something Henry Ford said, whether you think that you can or that you can't, you are usually right. So, I advise people to think that you can, and you probably will be able to do that. So thank you very much, and I'd be happy to